Hello, my name is Neal Shore. I'm a uro-oncologist from South Carolina in the U.S. It's a great pleasure and privilege for me to be with two of my very close colleagues and really good friends, Joaquin Mateo from Barcelona, Spain, Karim Fizazi from Paris, France. What an honor to present to you today on behalf of eCancer some of the really most relevant and interesting aspects of ASCO 2019. We're going to focus today on some of the new data that's coming out in castration-resistant prostate cancer, or for many of us who are not really devotees of the field, patients with advanced prostate cancer when traditional first-line treatments such as hormone suppression are no longer working. Prior to 2004, we didn't have any therapeutics approved to prolong survival for men who had metastatic castration-resistant prostate cancer after they had progressed after androgen deprivation therapy. So in 2004, we see the approval of the first taxane, docetaxel, a microtubulin inhibitor. Then 6 years later, in the US, we received the approval of Sipuleucel-T, works on T-cell activation. And then very quickly after that, in 2011, we saw the approval of cabazitaxel, a second taxane that had prolongation of survival in men who had progressed after docetaxel exposure. And very rapidly, almost at the same time, we had the approval of a first oral agent, abiraterone acetate with prednisone in the post-chemotherapy setting, followed by enzalutamide in the post-chemotherapy setting. Both of these oral novel hormonal agents prolong survival. Very soon after that, we had pre-chemotherapy studies for both abiraterone acetate and enzalutamide, also demonstrating survival prolongation. So suddenly we had two novel hormonal oral agents, an immunotherapeutic, as well as two taxanes. And then shortly after that, we saw the approval of the first radiopharmaceutical, radium-223, which also had prolongation of survival in 2013. And most recently, a year ago, we had the development or the approval of another novel hormonal agent, which delayed what's known as metastasis-free survival, known as apalutamide. So it's really been a tremendous amount of advancement in the last 9 years. Moving forward, we're going to discuss today the role of another novel oral therapy known as Parp inhibition, and we'll talk about some of the other therapies that are in additional trial development. So, gentlemen, thank you so much for being here. ASCO 2019, always great, always a lot of interesting information. Let me start with you, Joaquin. You gave a wonderful presentation on work that you had done previously on molecules known as PARPs. And so what I'd like you to address is, a little bit about how do PARPs work, but most importantly about TOPARP-A, and really what you presented this year is on TOPARP-B, some follow-up, really profound, interesting data.
Yeah, thank you. I mean, this is work that we started a few years back with the idea that maybe there are some prostate cancers that deserve a different way of treatment rather than the drugs we are using in the majority because of having a specific biological characteristics that other prostate cancers don't have. So the challenge we are facing is, one, to find these drugs to prove that they work, but also at the same time to understand what is the best strategy to find those patients who are going to benefit from these drugs. And this is why we ran this trial that has several steps. In the first part, that is called TOPARP-A, we reported this a few years back. What we did is we gave this drug, olaparib, that is a PARP inhibitor, to a group of patients with advanced prostate cancer without looking a priori to the different characteristics in terms of the biology of the tumors. We just treat them all and then correlated whether they did well or not with the treatment with the biology of the tumor. What we found is that those tumors that are incapable to repair the damage, that the damage is the insult that the tumor cells are having all the time, were more likely to develop a response to olaparib. And that kind of made sense based on other studies in ovarian or breast cancer and in other tumor types that suggested that those patients, primarily women, because it was primarily in breast and ovarian cancer, that had mutations in a gene called BRCA, there are two actually, BRCA1 or BRCA2, that renders the tumor incapable of repairing this damage, were highly likely to respond to this drug. So in prostate cancer, we saw the same. The difference that we observed were actually that it was not only when you inherit this mutation from your father or your mother, but actually in some cases it's the tumor that developed this mutation spontaneously. And it was very interesting to see that some patients that did not have this mutation but had mutation in other genes that do similar function also were responding to the drug. So this is why we did the second study that is called TOPARP-B that I presented here at ASCO 19 on a larger population where all the patients were selected based on sequencing of the tumor first to look at these particular mutations. And we treated a group of around 90 patients that had mutations in all these genes. What we saw is that, again, those who had these mutations in the BRCA genes, regardless of whether it was inherited or developed in the tumor, had very nice responses. I mean, like 4 out of 5 responded to the drug in a group of 30 people, and most of them for a long period of time. And again, we saw some responses in patients that had mutations in other genes. But we are basically facing 2 big challenges. One, some of these genes are really infrequent, so it's very difficult to validate the data in a big population. And the other is that some of the genes that are more frequent, and the best example is one called ATM, sometimes we see some responses, but many times we don't. And as now, we are still incapable of differentiating which of the patients with mutations in this ATM gene will be in the group that may benefit a bit or the ones that are not benefiting at all. And that's probably the homework that we are taking home from this meeting.
So that's a great summary. A lot of really important data. Oral medication that has a sort of a compendium diagnostic to it by looking at the genetic profile that really speaks towards more precision therapeutic, right? And so I think the 3 of us are all part of a larger phase 3 trial now known as the PROFOUND. And so, Karim, your thoughts on the role for PARPs, and what are you looking forward to in terms of that trial, perhaps also the trial that another PARP inhibitor known as the TRITON trial as well?
Right, as you rightly said, I think probably it's the first time we will really enter the precision medicine history for prostate cancer with the PARP inhibitors. It really seems, again, this is still debatable and controversial, but it really seems that we are quite able to identify who are the patients that might benefit. Of course, they don't benefit 100% of them, but obviously patients with BRCA1 or BRCA2 mutations are a very good candidate for benefit. Some other genes that are rarer, just as was just said by Joaquin. Now, ATM, I'm still struggling with the idea, and we probably need more data, but obviously across the programs, olaparib, rucaparib, niraparib, we don't see much benefit for ATM patients. Now, I'm saying that it's controversial because there are also some data suggesting that if you combine olaparib with abiraterone, you have superiority, or you may have superiority over abiraterone alone in a randomized phase 2 trial. But you and me, I guess, are old enough to have seen so many positive, apparently positive randomized phase 2 trials that did not convert into or translate into phase 3 positive trials. So I do think that the PARP inhibitors will be much more for patients with mutations. Now, the open questions, or amongst the open questions, are, does the efficacy that we see long enough to be meaningful for patients? And that, I think, is a very important question, because even patients with BRCA1, BRCA2 who respond may not benefit long enough. So this is really something we need to figure out. And as you said, PROFOUND will tell us, and tell us whether not only they respond, but also whether progression-free survival is being postponed. And of course, I really hope it is. And we should not wait very long to know, which is also very nice. Super big worldwide effort to conduct PROFOUND. Thousands of men screen, many centers open. It is doable to do that at the global level, and we will soon have the answer, which is by itself very, very important.
Yeah, I think you're absolutely right. I think in some of the TOPARP-B, you had some patients, though, who had really tremendous durability of response.
For some of them, they did, and these were patients in the 3rd line or later stage, so patients that unfortunately have very advanced disease. So in those patients, it is true that we achieve very long-lasting responses, but in some of them only. And again, we need to get better in understanding who is the subset that derives the most benefit.
And perhaps also on top of that, why patients do not benefit or why don't they benefit anymore. And perhaps we can circumvent that.
Yeah, like in so many other studies, both TRITON3 and PROFOUND are in very heavily pretreated patients, some of the sickest, but yet with reasonable performance status. And so I think that data will be forthcoming relatively soon. And it's certainly possible that sometime in 2020, both of these drugs could be approved and available for further consideration. So the field continues to blossom. I would be remiss if I didn't have an opportunity here to cover some additional CRPC things that have happened in the last few months. Karim, you were the principal investigator for the ARAMIS trial. Maybe just a sentence or two about what's interesting about that study.
Right. I mean, that's also a nice story because darolutamide is a drug which is invented in Finland that we tested in phase 1, and virtually all patients in the phase 1 program benefited. It was really impressive. First patient, second patient, et cetera, et cetera. And it was quite non-toxic during the phase 1. Actually, we decided to stop the phase 1 dose escalation due to PK data, not due to dose-limiting toxicities. Then ARAMIS was the very first phase 3 trial, pivotal trial, testing the drug in the non-metastatic castration-resistant space. And as you know, we were able to establish that the primary endpoint of metastasis-free survival was significantly, and I believe very clinically meaningfully improved, with about a 60% reduction in risk. Overall survival is still immature at this point. Still, we see a 3-year rate of 73% versus 83% for darolutamide. And on top of that, the quality of life data that we just reported are very reassuring. Basically, we're maintaining quality of life in these men mostly asymptomatic. We're reducing the risk of pain deterioration. We're reducing the risk of local symptoms because some of these men actually have local progression and not necessarily metastatic deposits that we were not able to see on the imaging. So, I mean, all green lights on top of a safety profile, which is just neat. Even the slight difference in fatigue, 16% rate versus 11% with placebo, totally disappear when adjusted by duration of exposure. And all the rest is basically nothing. No cognitive impairment, no hypertension, et cetera, et cetera. So very nice profile, and hopefully we'll have soon this drug for all the patients.
Yeah, so it's another great advance, right? I mean, so now we'll have a third drug potentially approved. It's not approved yet, but it's up in front of various, regulatory authorities. And it'll be another great possibility for physicians to treat patients with an mCRPC with what appears to be a much cleaner profile. But let's talk about some of the more earlier phase, but really interesting therapeutics. Actually, one's in the phase 3, and that's the PSMA antibody drug conjugate with lutetium, also known as the VISION trial. But then I'd like to also talk about this concept of BITE technology, BITE. Maybe, Joaquin, you want to tackle one of those?
I think that overall, targeting PSMA is showing to be a very promising strategy in prostate cancer. Probably we still have to get a bit better at it because we still don't understand exactly how the expression of this biomarker works throughout the evolution of the disease. But clearly, the data is very compelling in terms of patients benefiting from the drug. And hopefully, these trials that you mentioned will help us to position it in the landscape of treatment for patients.
Yeah. So you and I are both doing the VISION trial. I think there's like 60 sites worldwide, 30 in North America, 30 mostly in Europe. And so these are patients who are heavily pretreated. They've been exposed to usually at least 1 or 2 NHAs, clearly have had taxane progression, and then get this PSMA antibody conjugate with lutetium. How has your experience been so far? Certainly, we've seen a lot of lutetium-based institutional trials going on in Germany, but this is really, I think, to my understanding, the most unique phase 3 trial prospectively performed to really get an answer to the validity of using this therapy.
That's correct in this setting, and with this design, there's actually a second phase 3 trial against cabazitaxel, but you're very right. This is really the first time we will know truly what we're doing with PSMA lutetium to all the patients. The population is a population of quite advanced men with prostate cancer. They have exhausted most of the existing treatment. They might or might not have received cabazitaxel, and radium might be also an option, but honestly, there's not much remaining. In my experience, but again, we'll need phase 3 data, but PSMA luteation is usually quite well tolerated. Of course, patients might complain from dry mouth, and this is because the salivary gland expresses the PSMA, but it's not something very bad, let's call it like this, in my experience for my patients telling me it's okay, mostly. And some of them might also experience some GI tract symptoms, so because also PSMA is slightly expressed in the GI tract. So nausea can be a symptom. You need to use drugs that are preventing nausea. But again, generally speaking, it's quite well tolerated. Infusions are being given once every 6 weeks or so. And the data from Germany and also those from Australia that were reported a year ago are quite compelling. And that's also, to be honest, my experience in the few patients that either I treated in the trial or whom I sent to Germany in the last years. Many patients seem to be benefiting, and generally it's a quite tolerable treatment.
Yeah, it's a really great summary. And we're enrolling patients in that study now. I think it's enrolling very fast. And, you know, it strikes me that here we are right now in 2019, we have 6 therapeutics that have been approved that are life-prolonging, and then with the potential for PARP phase 3 rollouts that will similarly lead to a potential survival prolongation, and then PSMA lutetium, we could in the very near term have 7, 8 additional classes of therapeutics that prolong survival to patients who heretofore has been a really big unmet need. You know, we have significant prostate cancer cause-specific mortality globally. So we're able to keep patients longer life and also keeping them with fairly good quality of life. As you said in the data that you presented here at ASCO on darolutamide, that was particularly impressive. But let's talk a little bit, and we have a few minutes left, about this another really kind of cutting edge we mentioned a second ago is this concept of BiTE technology, which I think is absolutely fascinating. At least to me, it's essentially taking an immunotherapeutic and combining the tumor cell and the T cell without necessarily a payload, but working to basically combine the target so you end up getting an apoptotic effect. Your thoughts, gentlemen, on the BiTE technology?
Well, as you said, it's really promising. It's smart, which we all like. Based on what we know from the immunotherapy treatment, even in other cancers in the last years, it obviously has a potential in different cancers, including prostate cancer. And it's even better when you do have a strong target that you can target. And for example, PSMA is one. It's quite broadly expressed in many CRPCs. Most men with CRPC actually have PSMA positive cancers, which doesn't mean, by the way, that all their cells are positive, which is still an issue. But still, we're not talking about a minority of men with a biomarker that you need to identify, et cetera, et cetera. So no, I think the biotechnology is very nice. Of course, there are side effects, so we need to learn how to deal with them and be cautious. But I think it's definitely worth pursuing and there are several PSMA BiTEs that are currently under development, including some with no need for continuous infusion, by the way.
Right. So there could arguably another pathway that could be quite disruptive, and especially for patients who have potentially failed other lines of therapy and have been heavily pretreated with large tumor burdens. So Joaquin, maybe some final thoughts, because thanks to all the work that you've done, really pioneering
many others.
And many others, but they're not here right now, so I'm going to But yes, you're absolutely right. So, but with PARPs, for our colleagues who are listening, oral medication, but if we combine them or if we use them as a standalone therapy, what are some advice or some experience you've had in terms of adverse event profile?
The adverse event profile of PARP inhibitors is quite well described because, as I was mentioning earlier, these drugs have been used and actually are approved as several PARP inhibitors for women with breast and ovarian cancer or with subtypes of these diseases. The main side effects that we are observing are hematological toxicity, so decrease in the hemoglobin or the blood cell counts or the platelet counts, and that just requires some monitoring from the physicians, checking blood tests and stopping the drug every now and then when it's necessary. And it is true that in the ovarian cancer studies that were the original studies, there were some issues with nausea and vomiting, which actually in prostate cancer we are not seeing much. You would agree, probably because of the different distribution of the disease for patients with advanced prostate cancer compared to women with ovarian cancer that have much more disease in the abdomen, and maybe that also affects how they tolerate these drugs.
And we'll have an opportunity to talk more about this, but in order to really carefully and appropriately utilize these drugs, at least in trial for men with prostate cancer, for women who have metastatic breast or ovarian cancer, there has to be either a germline or somatic tissue testing to delineate that they have BRCA1, BRCA2, or some other rare HDR defects.
Mm-hmm. Yes, and until now, this testing in other diseases was done basically based on germline DNA, so looking for inherited mutations. And I think that in prostate cancer, but also in other tumor types today, there was another presentation in breast cancer, very interesting, is seeing that these responses also can occur when this mutation arises spontaneously in the tumor and were not inherited. So that means that the field should progressively be moved forward towards testing the tumor rather than the germline DNA, which is important, but testing the tumor will also tell you about the germline defects. Of course, testing the germline DNA has implications for identification of families at risk of developing other cancers, so we still have to pay attention to it. But I think that in order to implement these drugs in clinical practice, we have to get better at tumor testing.
Great points. So on behalf of eCancer, Karim and Joaquin, thank you so much. Thanks for everything that you do. Thanks for all the research and the papers that you're writing and the education. We really thank you, and hopefully this was beneficial and inspiring for additional trial enrollment, and also look forward to the therapeutics that hopefully we'll see to expand our ability to take care of our patients with advanced prostate cancer. Thanks very much.